The next subject we are updating us on is titled PITAVASATIN to prevent cardiovascular disease in HIV infection. Report from the REPRIEVE study that was presented at IAS in Brisbane, June 2023. And let me bring in my partner again, Professor Oche Agbaji. Hello, Prof. Today, we say that HIV-infected patients are no longer dying of diseases related to HIV and AIDS. But the data is still out there that death rate on other causes of death in people who are HIV negative appears to be higher in HIV-infected patients. Do you agree with this new data that is showing that HIV-infected patients may be dying of diseases not due to HIV, but are dying more of diseases not related to HIV than individuals who are HIV negative? I don't know whether you got the point I'm trying to make.
Yes, I think I got it. Thank you, Prof. It's a very important observation because as we all know, our HIV patients are living longer now. And so because they are living longer, they are at risk of developing other diseases that people that live into old age are also exposed to, other non-communicable diseases. In addition, HIV itself is also a source of chronic inflammation, and that also is an additional burden that can result in other complications and death.
And I think you are on point on that, because the statement HIV is a form of chronic inflammation. And this inflammation has actually been related to evolution of cardiovascular diseases. But this is what you have in knowledge. But we now have robust data from big studies that is now telling us that HIV-infected population at higher risk of developing atherosclerotic cardiovascular disorders. And something may be done to remove this little extra increase in death rate among HIV-infected population who are no longer dying of HIV-related causes. What they did in the REPRIEVE study is to look at a lipid-lowering drug they call PITAVASATIN and programmatically give it to individuals who have achieved the goals of antiviral therapy. An individual is said to have achieved the goal of antiviral therapy if the individual has become virologically suppressed, the individual has achieved immunological recovery, the individual is clinically well. That individual has achieved the goal of antiviral therapy. But for that individual, there's still a little increase in the risk of death related to atherosclerotic cardiovascular diseases. And that this increase in death may be preventable by the use of a lipid-lowering drug called PITAVASATIN. This was the data that the REPRIEVE study, was talking about. In that particular study, you see, they included individuals who are living with HIV age 40 to 70 years and are on very good antiviral therapy, effective antiviral therapy like I discussed earlier, and they have low risk of atherosclerotic cardiovascular disease. But the thing is, in the next course of 10 years, they are at risk of developing atherosclerotic cardiovascular disease if something is not done. So they look at this individual and they started to include them in a trial to give them routine PITAVASATIN. And they were followed up for more than a period of 5 years. What are they looking for at the end of the study period is to see which of the group that is receiving lipid-lowering drug compare with the group that is receiving standard of care will develop any of the stated atherosclerotic cardiovascular diseases, such as myocardial infection, such as unstable angina, such as transient ischemic attack, such as stroke, arterial revascularization, and peripheral artery diseases. These are the atherosclerotic cardiovascular diseases that were being measured in this individual over a period of 5 years. Among those that are programmatically given the lipid-lowering drug compared with those who didn't receive the lipid-lowering drug. And what did they find at the end of the day? First of all the patients that were enrolled into those studies, whether you are in the pitavastatin group or you are in the control group, you are first of all categorized as what they call atherosclerotic cardiovascular risk score. They enroll those who have a low score. At the end of the day, so that you follow these people up and see whether they remain, the low score remain, and then the risk of developing any of the major atherosclerotic disease does occur or does not occur. What they put in that score, your age, your sex, whether you are a smoker, whether you have you're already known sclerotic disease, whether your lipid level is, there are a number of items that is studied, and then they are able to put you at an ASCVD score. You are said to have a low SCVD score if your score is between 0 and 4.9. And of course, a borderline score between 5 and 7.4, an intermediate score between 7.5 and 20, and then, of course, a very high score if your ASVD score is more than 20. The people that were enrolled in this study are those that have low score, and they were followed up for a period of 5 years to be sure that they remain at that low score, and to be sure that pitavastatin is likely going to have effect in preventing people from developing atherosclerotic cardiovascular disease. What was found at the end of the day, they are measuring all the major ASVD metrics, and they are also collecting blood samples to know the level of the lipid, because they are being given lipid-lowering drugs. You see, at the end of 5 years, when they review the data, those that were on pitavastatin, their lipid level declined by 30%. Those that were not given pitavastatin, they only received standard of care, the lipid level was also found to decline, but only by 5%. And indeed, there was a significant difference. So that lipid-lowering drug has effect in those people that are receiving it. But does that translate to emergence of atherosclerotic cardiovascular diseases? And indeed, it does translate into, because the risk that an individual would develop heart-related diseases, such as heart attack, stroke, peripheral vascular diseases, and related illnesses that are put together as major adverse cardiovascular events, occurred much more in the people that didn't receive pitavastatin. And it is said that in those people that receive pitavastatin, the occurrence of what they call MACE is major adverse cardiovascular event. MACE declined by 35% in the people that receive pitavastatin. By the way, in our country, what are the lipid-lowering drugs that is available for us? Pitavastatin that is reported here, I'm getting to hear about it for the first time.
Incidentally, it's not one of those that is available. We have rosuvastatin, it's one of the very common ones. We have atorvastatin. I think those are the two common ones. Pitavastatin is not available routinely for us here.
You know why I asked that question? You see, because the take-home point here is the fact that the decline in incidence of MACE, when it was properly assessed, was much more than what can be accounted for by lipid-lowering effect of pitavastatin alone. So that maybe there's something in pitavastatin that has effect on decreasing inflammation in HIV-infected patients. We do not know. So why I'm saying this, why I'm asking this question, if we really want to duplicate what the Prof study is telling us, are we going to insist on the use of pitavastatin that we know is not available in country, or do we think the lipid-lowering drug available in our country may have same effect? This is the point. But I think on the whole, for now, we can begin to think that the use of lipid-lowering drug, whether pitavastatin or atorvastatin, may really strongly have effect, in preventing the evolution of atherosclerotic cardiovascular diseases in our patients that are now living long, as we expect the antiviral therapy to be achieving for them. Thank you very much for your participation in this meeting. You're welcome.